Hello, everyone, and welcome. My name is Jaisali Figueredo. I'm a clinical nutrition support pharmacist, and today I'll be presenting on the introduction to total parenteral nutrition in the adult patient. The objectives of this presentation include reviewing common disease states leading to the requirement of total parenteral nutrition. We're going to review macronutrient requirement for our adult patients, identify standard adult daily fluid and electrolyte requirements, discussing best practices for electrolyte management in patients requiring TPN. We're going to identify consideration and restrictions when dosing peripheral parenteral nutrition. And finally, we will be reviewing additives and medications that sometimes may be added to our TPN orders. The golden rule here is that if the gut works, we want to make sure we use it. In this slide, you see the preferred routes for nutrition in order. First, we want to start with oral, and whenever oral is not possible, we would then proceed with preferring enteral nutrition. And finally, as a last line, we would resort to parenteral nutrition. Some indications warranting the use of TPN include inability to tolerate enteral nutrition, as I just stated in the previous slide, small bowel obstruction, high output fistula, ileus, mesenteric ischemia, chyle leak, short bowel syndrome, gastric outlet obstruction, and finally intestinal failure that limits the GI absorption. There are several factors that are important to consider when dosing TPN formulas, and these include the patient's age, their weight, renal function, hepatic function, critical care status, surgical history, cancer, infection or sepsis, diabetes, fluid status, line access, and finally medications. There are three methods to use to determine caloric requirements for patients. The gold standard is indirect calorimetry, and it determines resting energy expenditure, abbreviated as REE. Predictive equations are also often used. Some of these include the Harris-Benedict equation, the modified Penn state, and Miflinson-Jewer. To note, there are over 200 predictive equations published on literature, and they have been found to be anywhere between 40 to up to 75% accurate. Predictive equations estimate basal energy expenditure, or BEE, and this is a close estimate to the actual value that indirect calorimetry would have. Lastly, you can use a weight-based approach when calculating and determining your patient's caloric requirements. And for adult patients, we often see 25 to 30 kcal per kilo per day be utilized. The weight used to calculate may vary depending on the patient's body mass index or BMI. In this slide, you'll see how to determine caloric requirements using predictive equations. We will be focusing on the Harris-Benedict equation, and as you can see, there are two different formulas depending on the patient's gender. You also will need to know the patient's weight in kilo, their height in centimeter, and their age. You will want to adjust the body weight that you plug into the equation and use ideal body weight when you're working up a patient who is obese. Finally, you can easily find these calculators online so that the formula in itself you don't have to fully memorize. Stress factors are to the right of the slide, and these are important to multiply your basal energy expenditure after you calculate it and compute it. The stress factor is attributed to the patient depending on what level of stress they have. So if the patient is otherwise okay and healthy, you would use a lower stress factor such as 1.1, 1.2. If the patient requires catch-up weight gain, you would want to use a higher stress factor such as 1.5. Depending on the overall stress level and condition that the patient may have, such as severe sepsis, trauma, or burn patient, you definitely want to readjust your stress factor. Once the BEE is calculated and a stress factor is assigned, we would like to start focusing on how to formulate the macronutrients in our TPN. It is important to review recent medical history and assess refeeding risk for the patient, and depending on the refeeding risk status, we'll opt for either a more conservative or a more aggressive calorie delivery approach. Refeeding syndrome can be defined as the potentially fatal shift in fluids and electrolytes that may occur in a malnourished patient receiving nutrition, whether it is enteral, oral, or parenteral. A patient who starts TPN will not be receiving their goal calories on day 1. The formula is adjusted over the course of 3 to 4 days until goal is reached. If the patient is deemed to be at high risk for refeeding syndrome, a more conservative calorie delivery increase is optimal. Well, how do you know if your patient is at high risk for refeeding? In 2020, the American Society of Parenteral and Enteral Nutrition, or ASPEN, published consensus recommendations for refeeding syndrome. A patient is automatically classified as high risk for refeeding syndrome if at least one or more of these are met: a BMI less than 16, unintentional weight loss greater than 5% in a 1-month period, or non to negligible oral intake for a period greater than 7 days. If a patient has at least 2 of the following, then the patient will be automatically classified as high risk for refeeding. If their BMI is between 16 and 18.5, if the patient had weight loss less than 5% in a 1-month period, and if the patient had none to negligible oral intake for a period greater than 5 days. TPN is a complex order as it can contain up to 40 ingredients depending on the formula. In this slide, you can see listed some of these, including macronutrients for energy provision, protein in the form of amino acids, carbohydrate in the form of dextrose, and lipid emulsion, the different electrolytes to add, including sodium, potassium, calcium, magnesium, and phosphate, vitamin and trace elements, and finally medication additives such as insulin, famotidine, and octreotide. Let's get started by reviewing how to determine fluid requirements for our adult patients. There are multiple approaches to determine fluid requirements, and the one bolded here is the one most often used, which is the weight-based estimate. Adult patients require 30 to 40 ml per kilo of body weight per day, and 25 ml per kilo is optimal for geriatric patients or patients who are fluid restricted. It is very important to review comorbidities as these may warrant either fluid restriction or increased fluid requirements. Definitely consider fluid restricting the TPN order if the patient has a history of congestive heart failure, renal insufficiency, ascites, or pleural effusions. On the contrary, consider increasing fluids if patient has high output fistulas, excessive vomiting or diarrhea, or GI losses via drains or surgical tubes. This pie chart shows the general macronutrient distribution ranges for adult patients. Depending on the comorbidities and medical history, TPN formulas are usually adjusted and customized based on the needs of patients. We will now review macronutrients individually. So starting with protein, protein formulations used to compound TPN are also called amino acid solutions. The usual dose range is anywhere between 0.8 to 2 grams per kilo per day. Some patient populations may require higher protein needs, such as trauma, burn patients, and patients who are actively on continuous renal replacement therapy, also abbreviated as CRRT. The dose approach for protein dosing in obese patients vary depending on the guidelines that you read, and one approach is to use 2 grams per kilo of ideal body weight if the patient's body mass index, or BMI, is between 30 to 40, and 2.5 grams per kilo of ideal body weight if the patient's BMI exceeds 40. Of note, it is important to commit to memory that 1 gram of protein is equivalent to 4 kilocalories. Moving along to our second macronutrient, carbohydrates. Dextrose is the IV form of carbohydrates, and the dextrose dose is calculated by subtracting total calories minus protein and lipid calories. When dosing dextrose, it is important to review the glucose infusion rate, or GIR, of the TPN formula. The unit of measure for GIR is in milligram per kilogram per minute. The recommended initial GIR range for new TPN starts at 2.5 to 3 milligram per kilo per minute, and the absolute maximum GIR for adult patients is 7 milligram per kilo per minute. If the patient has been on nothing by mouth or NPO status or is critically ill, it is recommended to not exceed 2 milligram per kilo per minute GIR on TPN day 1. And in general, most adult patients typically do not exceed 150 grams of dextrose on TPN day 1. Of note, dextrose is considered a monosaccharide, and 1 gram of dextrose is equivalent to 3.4 kilocalories, whereas 1 gram of oral carbohydrates is equivalent to 4 kilocalories. It is important to note the difference when calculating calories for IV macronutrients versus oral or enteral. Last but not least on the macronutrients are the lipids. IV lipid emulsions are used to provide fat calories for patients who require TPN. The dose is calculated by using 20 to 30% of the total goal calories as lipid calories. Similar to dextrose and glucose infusion rate, the lipids also have a lipid infusion rate maximum. For adult patients, this value should not exceed 0.11 gram per kilo per hour. There are multiple formulations available, such as MOF lipid, intralipid, and clinolipid, and all of these are 20% lipid emulsions, meaning that for every 100 ml of IV lipid emulsion, there are 20 grams of fat. MOF lipid and clinolipid were FDA approved more recently, and their formulations do vary from one another. It is important to always review the medication profile of your patient and be on the lookout for medications that may have a lipid emulsion base, such as propofol or clofidipine. For IV lipid emulsions, the calorie delivery varies depending on the percent the IV lipid emulsion has. For 20% lipid emulsions, every 1 ml delivers 2 kilocalories, whereas for the 10% lipid emulsions, every 1 ml delivers 1.1 kilocalorie. Every 1 gram of IV lipid emulsion provided delivers 10 kilocalories. And unlike oral fat calories, where 1 gram delivers 9 kilocalories, the slight difference here between IV lipid emulsion and oral fat emulsions is to account for the 1 additional kilocalorie coming from glycerol, which is an emulsifier used and added to IV lipid emulsions. In this slide, you can see the composition of IV fluid in terms of electrolytes and osmolarity. Normal saline is abbreviated as NS and is also known as 0.9% saline. It has 154 MEQs or milliequivalents of sodium per liter of solution. The IV fluid composition varies depending on their sodium content. 0.45% normal saline, NS, or half normal saline has 77 MEQs of sodium per liter of solution. And as the name says it, it holds half the amount of sodium than normal saline. Other variations such as a quarter normal saline also do exist. And lactated Ringer solution, abbreviated as LR, has 130 milliequivalents of sodium per liter of solution in addition to other electrolytes. D5W, or dextrose 5% in water, has no sodium. The difference in terms of sodium content in these IV fluids will be important when dosing sodium in TPN solutions. The chart in this slide shows a summary of the daily electrolyte requirements for adult patients as well as the recommended maximums as per the American Society of Parenteral and Enteral Nutrition, or ASPEN. Sodium has a daily requirement of 1 to 2 MEQ per kilo and a recommended maximum of 154 MEQ per liter. The 154 MEQ per liter should resonate as this is the same sodium content found in 1 liter of normal saline. We will speak individually about each of these electrolytes in the upcoming slides. Potassium, similar to sodium, has a daily requirement of 1 to 2 MEQ per kilo. The recommended maximum for potassium in a single TPN bag is 240 MEQs. Calcium has a daily requirement of 10 to 15 MEQs. Magnesium's daily requirement is 8 to 20 MEQs. And finally, phosphate's daily requirement is 20 to 40 millimoles per day. Note the unit difference here when dosing phosphate salts. The unit is millimoles instead of MEQs. Best practice approach when dosing electrolytes is to always correct electrolytes prior to starting TPN and to replete low or hypo values using electrolyte repletion protocols and adjusting TPN electrolyte doses as needed until normal levels are reached. In this slide, you can find the recommended electrolyte dosing for patients with normal chemistry panels. Dose adjustments are warranted given baseline chemistry panel abnormalities. Hyponatremia is more frequently encountered in patients receiving TPN than in any other hospitalized patient, and this has been associated with higher mortality. Therefore, optimal sodium dosing for TPN is very important. The recommended starting dose is half normal saline equivalent or 77 MEQ per liter. There are 3 sodium salts that may be used to compound TPN formulas. These are sodium chloride, sodium acetate, and sodium phosphate. Sodium chloride is our preferred sodium salt to use since amino acid formulations are acetate rich. Sodium acetate may be used if the patient has elevated chloride levels or low CO2 levels. And please note that sodium bicarbonate is incompatible with TPN solutions, and instead we use sodium acetate since the acetate is converted to bicarbonate in the liver. The sodium phosphate salt is used to deliver the phosphate requirements for our patients, and it is very important to keep in mind the amount of sodium it carries. 1 millimole of sodium phosphate has 1.33 MEQs of sodium. In this slide, you can find a very useful formula used to calculate the estimated serum sodium concentration change per liter of fluid administered to the patient. It is the sodium concentration in IV fluid in MEQ per liter subtracted by the serum sodium concentration divided by the total body water plus 1. Total body water equations are gender specific, and for males it is 0.6 multiplied by the patient's weight. For females it is 0.5 multiplied by the patient's weight in kilos. It is important to keep in mind the comorbidities and medications that may influence serum sodium levels, and as the general rule of thumb, it is ideal to find the etiology causing the sodium abnormality and then targeting it to obtain normal serum sodium levels. It is best practice to approach sodium dose adjustments in TPN in relationship to the composition of IV fluids. In general, dose increases or decreases may be done following the content of sodium in IV fluids found to the left of this slide. The maximum sodium that you should give a patient in TPN would be normal saline equivalent or 154 MEQ per liter. It is important to assess fluid status and restrict or replete as needed. If serum sodium level is at a very critical value, either very low, a level below 120 MEQ per liter, or a level very elevated, greater than 160 MEQ per liter, it is best practice to just hold off on delivering TPN and prioritizing sodium correction. The maximum serum sodium correction in 24 hours is very important to commit to memory, and that is 8 to 12 MEQ per liter in order to avoid neurologic toxicities. Next, we will review potassium. The recommended starting dose for potassium is somewhere around 0.5 MEQ per kilo, or approximately 40 to 50 MEQ in the total entire bag. This quantity varies depending on the baseline potassium level, of course. The goal is to maintain a level at 4.0 MEQ per liter. And just like sodium, we have 3 IV potassium salts that we use to compound our TPN solutions. These are potassium chloride, potassium acetate, and potassium phosphate. And of note, for the potassium phosphate, we use it again to dose the phosphate ingredient in our formula, but we should be aware of the amount of potassium it holds. Every 1 millimole of potassium phosphate delivers 1.5 MEQs of potassium. When it comes to potassium, the general rule here is that every 10 MEQ increase or decrease of potassium approximately changes the serum potassium lab value by 0.1 MEQ per liter. In hyperkalemia states, The best practices are seen here in the lower part of the slide. If your serum potassium is in a range between 5.0 to 5.5, it is best practice to halve the current potassium dose in TPN. And in instances where the potassium level exceeds 5.5, it is best practice to remove all potassium from TPN and definitely consider interrupting the current infusion until the next bag without potassium becomes available. Here we have the recommended starting point for calcium, and that is 8 MEq total per the whole entire bag. We have two salts, the IV calcium gluconate salt and the calcium chloride salt. The gluconate salt has 4.65 MEQs per each 1 gram that we deliver, and the chloride salt is 3 times more potent, and it has 13.6 MEQs of calcium for every 1 gram. The calcium gluconate salt is the preferred one to use for compounding TPN in order to prevent incompatibilities, and the calcium chloride salt is not used to compound TPNs at all. It is important to always remember to calculate the corrected calcium if the patient's albumin is low, meaning less than 3.5 gram per deciliter. And in the end of the slide, you can find the corrected calcium equation. For magnesium, the recommended starting point is 8 MEq per day. The goal is to maintain a level greater than 2.0, and the sulfate salt is the preferred instead of the chloride salt to prevent incompatibilities when compounding TPN. It is important to remember that 1 gram of magnesium sulfate has 8.1 MEQs of magnesium. Phosphate is the last electrolyte that we will be reviewing. The recommended starting dose is 20 to 30 millimole per day in our TPN bags, and the maximum will be something like 40 millimoles in total. However, note that some patients may exceed this maximum. The recommended adjustments to make will be in increments of 5 to 10 millimoles per day, and the overall goal is to maintain a normal level somewhere close to 3.0. We have two different phosphate salts, the sodium phosphate or the potassium phosphate, as we previously mentioned when we were reviewing sodium and potassium salts. Sodium phosphate has 1.33 MEQs of sodium for each 1 millimole of phosphate, and potassium phosphate has 1.5 MEQs of potassium per 1 millimole of phosphate. In this slide, you may find the dosing best practice for phosphate. For renal insufficiency patients who have creatinine clearance less than 30 ml per minute, it is ideal to halve the starting dose of phosphate and to increase by 5 to 10 millimoles per day as needed until your phosphate level is normalized. Caution with concomitant calcium content in TPN solutions. Calcium and phosphate crystals may precipitate in solution and can cause a lot of complications to our patients. The calcium-phosphate ratio is calculated by something called a 45 rule, and the equations here at the bottom of the slide. It is the calcium content in MEq per liter plus the phosphate content in millimoles per liter, and this value should always give you less than 45. If you exceed 45 when adding these two values, the chances of precipitating in solution are elevated. There are two main forms of parenteral nutrition formulas, peripheral parenteral nutrition or central parenteral nutrition, otherwise known as TPN. PPN, peripheral parenteral nutrition, is normally used short-term for a period less than 7 to 10 days. And there are several restrictions that come with using a peripheral formula. The osmolarity must never exceed 900 milliosmoles per liter. The final dextrose concentration should be less than 10%. The final amino acid concentration should be no more than 4%. The calcium concentration should be at 5 MEq per liter or less. And finally, the potassium concentration should be between 40 to 60 MEq per liter or less. As I just stated, the osmolarity for peripheral formulas must never exceed 900 milliosmoles per liter. The osmolarity for central formulas must never exceed 2400 milliosmoles per liter. Depending on the EHR that your hospital uses, you may find the osmolarity be automatically calculated for you when you're putting together a TPN formula, such as the one seen in this picture, if you're an Epic user. It is important to note the different types of venous access devices. Some are central and others are peripheral. PICC lines, portacats, Hickman catheters, and Brovia catheters are examples of central catheters, whereas midline catheters or mid-clavicular catheters are examples of peripheral venous access devices. It is a standard recommendation to add vitamins and trace elements to all TPN orders, unless of course the patient has a documented vitamin or trace element allergy. There are instances where we would like to also omit trace elements, and this is due to perhaps parenteral nutrition associated cholestasis. Parenteral nutrition associated cholestasis is most often found with elevations of alkaline phosphatase and total bilirubin. Some other medications that may be added include famotidine and octreotide. Famotidine doses will be between 20 to 40 milligrams, and you want to make sure you renally dose adjust if needed. Octreotide may be also added for patients who are experiencing high outputs or losses via ostomies or surgical drains. The starting dose is 300 micrograms, and it may be increased to 600 micrograms if the patient does not have an adequate response. The maximum dose that we would recommend would be 900 micrograms per day. Insulin is another medication that we sometimes use in our TPN solutions, and we begin adding insulin to TPN solutions if the blood glucose of the patient is consistently above 180 milligram per deciliter and the patient's already on a sub-Q correctional sliding scale or on an insulin drip. We recommend adding regular insulin to our TPN only. Other types of insulin are not compatible. The usual starting dose would be 10 units of insulin for every 100 grams of dextrose. The recommendation here is to start always with 10 units and then titrating up as needed. The following day, it is important to closely evaluate the POC or the point of care blood glucose checks and the sliding scale requirements that the patient needed during the last 24 hours. After you add all those units, you would go ahead and obtain 50 to 75% of these and add it to the following TPN bag, and continue to do this until your finger stick glucose is maintained adequately at levels below 180 milligram per deciliter. When ordering TPN, it is important to check a point of care glucose every 4 to 6 hours. The administration method for TPN may vary from continuous, meaning 24-hour continuous infusion, to cyclic TPN. And cyclic TPN are preferred infusion methods for patients who are chronically TPN dependent. Cycling the TPN makes the patient more independent and be able to be disconnected from the IV pump for a number of hours in a day. The recommended starting point for cycling TPNs will be 16 to 18 hours. This means that for 16 hours, the infusion would run and the patient would rest for the remaining 8 hours. Whereas if you were to select an 18-hour cycle, the formula would infuse over an 18-hour period and the patient would rest for 6 hours. In this example, you can see how to go about and calculate the rates for a cyclic TPN when deciding to go for a 16-hour cycle. If you have to account for the volume of the formula, so in this example, it's 2,000 mLs or 2 liters, subtract 100 mLs from the total volume and then divide by 2 hours less than the total infusion time, meaning in this example 14. So it would be 1900 by 14 hours, and approximately would be 135.7, always round to the nearest number, and then multiply it to get back to what the full volume will be infused after 14 hours. In this example, will be 1904 mLs. You would then proceed to subtract and find the difference or the remaining mLs in the formula, and this will be the infusion that you would deliver in the remaining 2 hours of the infusion, and 96 divided by the last 2 hours, that's how you get 48 ml per hour. In this example, the cyclic TPN should run at 136 ml an hour for 14 hours, followed by a 48 ml an hour rate for the last 2 hours. Patients who are on TPN require daily monitoring. In this slide, you may find some of the items that we must check on a daily basis for our patients who are TPN dependent. Things like line access, strict intake and output, IV fluid orders that are placed in addition to TPNs that perhaps should not be there, electrolyte replacement orders placed in addition to our TPN. We definitely want to make sure that we're reviewing the chemistry panel and our CBC. And we're also very vigilant of blood cultures if infection is suspected. Finally, we want to make sure to review nutrition-specific tests such as indirect calorimetry, 24-hour urea nitrogen study, and vitamin panel as needed. And of course, medications, as these sometimes can produce side effects that could warrant a dose adjustment in our TPN. This concludes the introduction to TPN presentation. Thank you so much for listening. If you have any questions, please feel free to write them down in the comments below or reach out to me directly. Have a great day.